Welcome to Raaonline. Today's topic is anemia complicating pregnancy. So how do we define anemia? So it is an insufficient hemoglobin to carry out oxygen requirement to tissues, and anemia is characterized by hemoglobin concentration less than 11 gram or a hematocrit less than 0.33. So during normal pregnancy, there are various changes. The plasma volume expands by 40 to 60% and the red cell volume expands 20 to 50%. So there is a physiological anemia. It's called as dilutional anemia, which develops and there is a fall in the normal hematocrit value. The hemoglobin levels lower than 10 grams per dl suggest the possibility of pathological process such as a nutritional deficiency, and the prevalence of anemia in pregnancy increases from 8% in first trimester to 12% in second trimester and 34% in third trimester. So as the gestational age is advancing, there is an increase in the prevalence of anemia. Presently, there is no definitive evidence whether the hemoglobin threshold should be 7 or 8. However, some studies do indicate that there is an increased risk of intrauterine growth restriction with effects on fetal growth when the hemoglobin falls below 8 gram percent. So how does WHO classify anemia? It classifies as mild, moderate, severe and very severe. So these categories are 10 to 11, 7 to 10, 4 to 7 and then very severe. And what is physiological anemia of pregnancy? So physiological anemia of pregnancy is also called as dilutional anemia of pregnancy, and it is basically because of the disproportionate rise in the plasma volume and the blood volume. So the plasma volume in pregnancy expands by 46 to 55%, whereas the RBC volume expands less. So thereby there is a dilution of the RBC and this leads to the dilutional anemia of pregnancy. So there are various changes in the parameters during pregnancy. So normal plasma volume in a non-pregnant individual is 2.6 liters. In a pregnant individual it is 3.85 liters. And there is a around 1.2 liters increase in the plasma volume. The red cell mass in a normal individual is 1400 and in pregnant individual it becomes 1640. Hemoglobin normal is 12 to 14. In pregnancy the normal hemoglobin is 11 to 12. The red cell million per mmq 4 to 5 in normal individual and 3 to 4.5 in a pregnant individual. PCV 0.36 to 0.44 in a normal individual, whereas 0.32 to 0.36 in a pregnant individual. Mean corpuscular volume also falls in pregnancy. The mean corpuscular hemoglobin concentration falls in pregnancy. The serum iron also falls in pregnancy. The total iron binding capacity is increased in a pregnant individual. The percentage saturation is decreased and the iron requirement from 1.5 milligram per day goes up to 4 milligram per day in a pregnant individual. So when do we call it as physiological? So hemoglobin should be at least 10 gram percentage. If it is less than 10 grams, it is a pathology. It's not physiological anymore. The total RBC count should be at least 32 million. If it is less than 32 million, it is pathological. The RBC morphology is always normal in the dilutional anemia and the hematocrit is at least 30%. So what is the cause of anemia in pregnancy? So it can be a physiological, we saw the dilutional anemia, or it could be pathological. The pathological causes could be nutritional, iron, folic acid, B12 or protein deficiencies. It could be hemorrhagic, acute or chronic blood loss, hemolytic, which can be familial or acquired, or it could be bone marrow insufficiencies or hemoglobinopathies. So erythropoiesis is confined to the bone marrow in adults. And in pregnancy, there is a secretion of placental lactogen from the placenta and progesterone is increased. So that is why the erythropoietin hormone is increased in pregnancy, and erythropoietin is produced by kidneys 90% and liver 10%. So what is the process of formation of RBCs? Pronormoblast, normoblast to reticulocyte to a mature non-nucleated RBC. Average lifespan of RBC is 120 days and hemoglobin ultimately breaks down into hemosiderin and bile pigment. The minerals required for erythropoiesis are iron, traces of copper, zinc, cobalt. The vitamins required are the folic acid in the later stages of DNA synthesis, and B12 is required for the early stages of RNA synthesis. So deficiency of B12 results in a deficiency of both RNA and DNA, whereas folic acid deficiency leads to a deficiency of DNA. Vitamin C is required for the conversion of folic acid to folinic acid, and proteins are required for the synthesis of the globin moiety. So what is the magnitude of the problem? Globally around 30%, in India it is around 40 to 90% depending upon the state we are talking about. The maternal mortality is high, 600 to 700 per 1 lakh, and anemia is directly responsible for 50% cases and indirectly responsible for another 50% cases, as anemia can also lead to PIH or predispose to these conditions like malaria, death from APH, BPH, cardiac disease, and death from obstructed labor. So anemia is directly or indirectly the major cause of maternal death. So what is the daily requirement of iron during pregnancy? It is 4 mg per day. Less than 20 weeks, in the first half of pregnancy, the requirement is just 2.5 mg per day. From 20 to 30 weeks, the requirement is 5 mg per day. And after 32 weeks, the daily requirement of iron is very high, that is around 8 mg per day. So our daily diet can contain 10 to 20 milligrams of iron, and it is absorbed in a non-pregnant individual, which is 10%. 1 to 2 milligram iron per day is absorbed, and transferrin transports iron, and the 75% goes for the erythropoiesis, 10 to 20% is stored as ferritin in liver and heart, and 5 to 15% is for the other processes. Daily around 1 to 2 milligram iron is lost from the desquamation of the epithelia. There is as such no physiological excretory mechanism for iron. Now how the iron amount is controlled? There is a mucosal block theory which says that the iron in the food at the level of the mucosal cells is absorbed, and then it is stored as apoferritin, and then comes as ferritin, and then it goes into the plasma, and then in the plasma there is formation of and saturation of transferrin, and then it goes into the liver and into the muscle, bone marrow, and other tissues.